This is the best part of the whole show.
You ready? Let's go!
Hello everybody and welcome back to SPT with JZ. We are currently on episode 5. I'm Zach Carson.
I'm Josh Griffin.
And we are ready to rock and roll through our 6th week of the program here at Grand Valley State. We want to start off with saying this week was pretty tough. We had a lot of, as you know, talked about last week on the video, we had a lot of exams. We had a quiz, we had 2 exams, we had a practical, so it was a lot of hunkering down, studying notes, a lot of people sacrificing some hours of sleep. I came down with a cold on Tuesday night, so I've had a little bit of a scratchy throat and I'm a little bit stuffed up right now, so if I sound even more nasally than normal, that is why. And I apologize if I sound like the lead singer from New Found Glory at any point, or Green Day. I mean, they're both really nasally, so.
Okay.
Tough week, but we made it through. You know, everybody goes through tough weeks. You just gotta, you know, remember what the important things in life are, and that everything kind of proceeds forward no matter what. Don't look back, only look forward. So with that being said, let's go ahead and jump into the content. We're gonna start off and rattle through it all. Josh is gonna take over from here to get us started.
All right. So like every week so far, we've started out with anatomy lecture, and we haven't had any. We had our exam a couple weeks ago, so we're actually getting geared up again for another exam in 2 more weeks. So we've moved through the cranial nerves this week. That was our big hit that we took as far as time wise. Very important to go through in both the lecture and in the lab, because they're such small structures that it's not always the easiest to pick up. We went through the ventricles of the brain, more of the just vasculature in the brain. Ventricles, meninges, so I've got to go through the circle of Willis in both lecture and lab this week. It is nice to be able to see it on a actual brain, because it's one of those other blood flow patterns that is you're going to have to draw it out 100 times, think it through, different views. Just one of those things we're going to have to hit home quite a bit, just like the cranial nerves. Just another structure and a flow that we can recreate in as many ways as possible to make it stick. So there's a lot of mnemonics that we can use for different things, and we'll be using that for the cranial nerves as
What are you
well.
going to use?
I don't know.
You don't know?
No.
My go-to. O, to touch and feel very good velvet.
Okay.
Such heaven.
Such heaven. There you go.
Have you ever felt velvet?
One time.
One time?
I don't remember when it was, but like one time I'm pretty sure. So this week we've stuck in the brain, and then in lecture we did go into facial muscles. So that's one thing that we didn't get to do in lab. We've had some of the bodies have had some mold growing on them, so we're trying to kill off the mold so that we can look at it on the structure. But we'll be moving into that next week. That's all I have for anatomy this week, actually. So moving on to our kines, where we had a lecture and our practicals this week. So Zach will take us away.
When Josh says that's all you had in anatomy, the cranial nerves are a beast. That's
quite a bit.
You could do a whole exam on just the cranial nerves probably. So that's definitely a tough topic to cover and kind of master, if anybody ever does, if you're going to be like a neuroscientist maybe.
Mm-hmm.
So yeah, kinds this week we had a quick lecture to start the week off, and then we had our lecture exam and then our practicals this week, so we're going to talk a little bit about all those things. In the lecture portion, we wrapped up our spine, cervical spine kinematics, so we talked a little bit more about how the cervical spine moves, how the upper cervical versus the lower cervical is coupled, so the upper cervical is always coupled to the opposite direction, and then the lower cervical is coupled to the same direction. Again, that coupling pattern just is talking about the quantity and the quality of the movement. So we did learn a little bit about that and how it kind of mimics the movements of the thoracic spine. So it was a pretty easy concept to grasp as long as you could kind of master that upper cervical versus the lower cervical and know that there was 2 different things going on. So in lecture we talked about that, and then we also touched on some of the muscles, the suboccipital muscles, the rectus capitis, posterior major and the minor, and then the obliquus capitis, superior and inferior. those attachment points, how they enacted on the head, and we learned a lot that these are kind of the muscles that generally cause a lot of tension in the head and the aponeurosis, and kind of lead to some headaches, and there's something that we're probably going to be seeing and encountering in the clinic quite a bit. So we talked a little bit about that, and then we mentioned how bad postural control can lead to tight muscles, especially in those muscles in the back. If you get into that like forward head position or shoulders rolled, you get the tight muscles, which leads to tension, which leads to possibly headaches or other things that can go wrong. And then we talked a little bit about the crossed muscle syndrome. So if we have a tight abdominal structure due to our pelvis, you're going to have tight hamstrings and glutes, and then you'll have loose through like the iliopsoas and the hip flexors, and then like loose or lengthened erector spinae. So we talked a little bit about that, and that can happen anywhere in the body. So that could be crossed from here to here and down here to back here, or through the hips in different regions of the body. It just leads to that pattern. So that was kind of a brief thing that we touched on in lecture, and then we jumped right into the test on Wednesday. And I would say the test was as expected. There were a couple curveball questions that were covered, but covered very briefly. And it definitely caught me off guard, because I was like, oh, I remember mentioning that, but it was like slide, mention, next, and didn't really kind of elaborate that information. So it was a lot of those coupling patterns, just like we expected. So just like we anticipated too, I looked over, and not to look over at anybody else's exams or anything, but I saw lots of people mimicking the facet joints, just kind of slowly going through the side bend and the rotation and what those facet joints were doing. The different questions were kind of leading us. I remember one that was like, what does the neck do if you look up to the right? And people are looking up to the right and trying to just think about it and visualize it. So it was kind of fun to see that. And I would have loved to been in our instructor's shoes up front, just to kind of watch and chuckle at everybody doing the same thing. But it was as expected. I don't think there was anything way from left field. It was just, if you knew the coupling patterns and you knew your stuff, you probably did all right. And as long as you got that pattern right on one question, it led to the next 3 or 4 questions, you'd be all right. If you didn't on the first question, then you're probably completely opposite.
Which is where I think most people are nervous.
A little bit nervous.
The first one, then that's like 8 points, I think, right there within 4 questions. So
yeah.
We'll see how our scores come back. We haven't learned yet on that, but
We'll see.
yeah.
All right. So that was the lecture portion. Then we had practicals. Josh had his practical on Tuesday. I had my practical on Thursday. So we're going to jump into those experiences, and Josh is going to talk about his experience first.
Yeah, so I think most people are pretty nervous going into their first practical experience. You can practice on your part. One thing that's nice is that we get to practice on our partner. Find out about a week ahead of time, I believe, so that you can find some structures and just go through your lab list and palpate on your partner, so that when you get into the lab and you're nervous, then your hands are actually a little more familiar with the body that you've been working with. So when I walked in, I was pretty nervous, but I was kind of in game mode at that time. I usually get pretty jittery right before the exam, but once I step through the doors, then it's a whole different mindset. I think you just gotta focus, like tunnel vision in a way. And I was able to get through it. I did better. I don't know if I did better than I expected, but I was pretty confident when I was going through most of my exam. The only thing was not knowing some of the origins and insertions. I knew most of them, which I spent a lot of time doing that, and I think everybody did. That's where a lot of the time is. Because when we do the palpation, I think that's the easy part in a way. I mean, you should, with memorization through O's and I's, it should be easy. But I think just knowing how to test for a muscle, or to test like that you're on a structure, like a ligamentous structure even, that's kind of more natural in a way to perform that, instead of trying to recall information that you've just been putting to memory in that way. Working with your hands, for me personally, is a little bit more easy, I guess you can say. But we'll see on different structures. If we get into the arm later, we might have some more issues. But it was a good experience. I think getting feet wet through the first one, pretty confident going into the next few, just knowing what's to be expected. And I'm glad I did the quiz the week before, because that was a good precursor to the actual exam itself, or the actual practical. So it was good, good experience. Most people, I think, felt pretty confident after the fact that they're going to be able to do this, just as we have with our other exams. Just getting through the first round is probably the most nerve-wracking, because you don't know what to expect. Regardless if it was undergrad to now graduate school, we really don't know what to expect, but we've survived so far. Clearly, we made it. We're a little tired, maybe a little sick, but we've made it through. So my experience was pretty as expected, I think, just like the lecture portion. They're pretty straightforward on what to expect throughout.
Yeah,
So,
and they'll help kind of walk you on a little bit
Mhm.
if you're missing something,
right.
which is nice. They throw a few extra questions at you to help kind of walk you onto the target. My experience is a little bit different than everybody else's, just because I did have that one semester at Wayne State. So I have had practical experience, which helps calm my nerves a little bit. But at the same time, my military experience and like my job as a strength and conditioning coach, where I'm working with people, I have a pretty calm demeanor. As I like to think so. I mean, I definitely get the jitters just like anybody else, but I have a pretty good way of bringing it down and kind of leveling it out, and then focusing my approach as I go into things. So I got in there, and with that demeanor, I'm always confident, I'm going forward. And then he asked me, the first structure he gives me is the iliocostalis, and I was like, all right, cool. And in my mind, I'm like, where is the iliocostalis at? But I go through my introduction, and I'm like, all right, I'll just find it along the way, I get along. And then still, I'm like, oh yeah, that's right, it's on the back. So that was like the start, but everything after that was like boom, smooth, smooth, smooth. And it was just one thing after another, and everything that he gave me I felt confident in. The one thing I was a little more surprised on, I think I got 2 muscles in the entire practical. So we had different regions of the body that we learned: the thorax, the cervical spine, a little bit on the face and TMJ. And like I was anticipating muscles, a lot of muscles, and then maybe a couple of structures: spinous process, transverse process. Mine was a lot of just bony structures. I was like, okay, that's cool. I mean, all right, what are you going to ask from that? So they would ask like attachments to those bony structures, or like the arthrokinematics of those joints. So it was different than I expected, but I still had the information up in my noggin to knock it out. So I didn't have any issues there. But the same thing, everybody goes in there nervous, but then they come out and everybody cheers on their classmates because they're like, it wasn't that bad, don't worry. And I'm like, yeah, I know, I'm not anticipating it to be that bad. But everybody has their own mindset of what it's going to be like. But now we all have a benchmark, and I think going forward, everybody will be a little bit more comfortable with what to expect, and they'll be able to just roll in there. The structures might get a little bit tougher, but at least their confidence will carry them through. So I think everybody had a good experience there.
And I think everybody's starting to be able to understand how to feel for structures now too. Because when I was first going through palpation labs, I was not feeling things at all. Like I would go through a whole day and be like, I couldn't even tell you where a transverse process is. Like I couldn't feel it for the life of me. But then as I went, and you just practice more, it's a learned skill that we never had before. But the more you practice, the better, or the more focused your practice is, the better you're going to be. The saying, practice makes perfect, not always true. Perfect practice makes perfect.
Yes, that's correct.
So
I agree with that 100%.
So moving on from our practical in there, so that's what we talked about. Just one. No, we talked about 2 exams so far. 1 practical, 1 exam.
Yep.
So
Yep.
going on.
All right, so let's roll into foundations, and we're going to talk about the lecture and the lab portion of foundations. Last week we talked a little bit about sensory testing, so we learned a little bit about the dermatomes and the peripheral nerves. This week it was upper and lower body range, well, not range of motion, goniometry. So we measured range of motion, and next week it'll be like muscle length testing and those things going forward. So we talked a little bit about upper and lower goniometry. What's the difference between range of motion, flexibility, and muscle length? So range of motion was just the joint itself and the arc that it goes through, so the range of motion that you have through a joint. Muscle length was actually taking that muscle and stretching it into length and seeing how much length they could get. So Well, we haven't actually tested on that yet. We just did the range of motion portion. And then flexibility was muscles, ligaments, tendons, and joint capsules being the overall result of the ability of that joint with all those things included. And we talked a little bit about functional range of motion, what it meant, and like what are some things that we could do for functional range of motion. Squat testing, toe touches, just doing some rotations behind the back, just to get an idea of how that person moves functionally. And then joint active and passive range of motion. So active range of motion obviously is what the patient or the person is able to do on their own, and then passive range of motion was simply what can a person take and apply additional force to get additional range through a different joint. So it can be normal and it can be abnormal. We learned all the different ranges, all the different joints have kind of a standard range, although those can be altered one way or the other based on the person, because everybody's a little bit different. Just because you don't meet the active range of motion requirements doesn't mean you're injured by any sense. It just means you might have a slightly different joint structure, or maybe just like some ligamentous tautness that doesn't quite get you where you need to go. So that's kind of what we learned this week. It was kind of fun getting in there and doing those measurements, and we'll talk about that in a little bit. But then with the passive range of motion, one thing you have to really be aware of is the end feel of a joint. So there's a bunch of different end feels, and Josh is going to touch on those real quick.
Yeah, so this is like where we're pushing the client through, like he said, their range of motion. So say we're doing an elbow flexion. So they're going to go to a certain point, and then the therapist is going to push just a little bit farther, not to pain, but to where they feel no more motion. So we have like a soft end feel. So it's kind of like with your knee. You have the gastroc and the hamstring. Those muscular structures are gonna stop the flexion of that knee at some point. So for me, I'm gonna have a little bit less knee flexion than maybe a female that doesn't have as much muscular tissue. So it's a softer like infield. It's not gonna be like an abrupt, and it's more of a gradual into that range. A more firm one would be the shoulder. And then the hardest one is the elbow, I think. It's elbow, and it can be the knee as well. So extension through the elbow, you're going to have the bone on bone, and that's where your end's going to be just an abrupt, no pain, but just it won't be able to go any farther because of those bony structures running into each other. So like abnormal infeels, though, you can have an abnormal soft feel to it, and it can like occur sooner than normal, or like actually later than normal. And that's usually due to like edema or like some fluid in the joint area. Another abnormal firm is like if the muscle is shorter, so it's kind of like a contracture in a way. I feel that's what I think of as like an abnormal infeel. I don't know if that's what you think of.
Contracture would be like a permanent.
Okay.
Like an adhesion though.
Okay.
Could be something that you could work through. But basically both of them are due to like immobilization of a joint, yeah.
A little bit of tighter ligaments over that muscle. And then your hard abnormal infeels are like can be like a fracture almost. And then an empty one is also like you don't feel where the bone should be. So that would be your infeels, and we haven't done that one yet. Like we just talked about, we did range of motion with the goniometry. Next week I believe we're palpating through, or like pushing through
a little bit more
to feel those infeels, so they can feel it on a person. I think it'll be difficult because we're really healthy. Most of us are pretty healthy, so we're not going to feel the like really abrupt, abnormal infeels. I don't even know if we're going to be able to fake that as easy, because it's usually like it's a condition that somebody's going to have. Like we've been able to fake some things through our being a patient, trying to give real life scenarios to each other through our dermatomes. We could like say, oh, I didn't feel this, or I didn't feel that. But when it comes to like muscular motion, it's going to be a little bit more difficult to.
Yeah, and I think we found out when we were actually in the lab that it was tough because we got some worksheets where the patient had to fake ranges of motion, and it'd be like, oh, 60 degrees of active shoulder range of motion. But then they would do it, and then we would go to measure it, and be like, 85,
Yeah.
and they'd be like,
No.
slowly move back down. You're like, okay. So,
But it was good because we're getting more practice on,
yeah,
we're just seeing how accurate we are with our measurements too. But it is hard to be the patient and try and guess the correct range
Yeah.
of motion.
so that was, and I was talking to one of the instructors afterwards, and I was like, yeah, that was probably the hardest part, trying to figure out where you were at. But he said that also gives you a feel for when you are working on a patient, what you're looking for, because you're thinking about it while you're faking it, and you're thinking about the different ranges. Okay, this is 90, this is 180, and then just like being able to figure out all the ballpark figures in between, because then when you look at a patient and you just have them do some basic testing, you're like, oh, well, I'm thinking that shoulder range of motion might be an issue, so I'm going to go ahead and measure that and put it down in my notes for further reference. So that, yeah, that's what we kind of got to do in the lab this week, and it was tough learning how to handle that goniometer and actually supporting the person's limb while you're also measuring the limb, and it's just something that we have to figure out how to handle. Again, we're just rooks at this
Yeah,
whole
a lot of practice still.
game, so
Adding a lot of new skills this
Yeah.
whole semester, and we've picked it up, I think, for the most part pretty well as we've gone along. It's just gonna be another skill to practice on multiple people many more times.
Yep.
So
100.
it's good. All right,
Cool.
going on clinical science.
Yeah, let's we can do that, or evidence-based.
You go evidence-based.
All right,
I go
let's do it.
clinical science.
Let's do evidence-based real quick. All right, evidence-based practice, again, pretty short stuff. We did have a quiz on Monday. It was pretty straightforward, straight out of the slides. She did throw like a database question in there, that complete curveball for me.
Yeah, I didn't
But,
look at it. It was in the notes. It was in the notes.
It was in the
Just
notes.
Didn't look at it
Yeah.
as close as I should have.
It was like Cochrane database. What are the pros and cons? I don't know.
Pro is it? I can find
Looks-
things on it. I guess.
Looks good.
Yeah.
So we started talking about like the nuts and bolts of research appraisal this week. So again, I'm going to reiterate this. The 5 steps of evidence-based practice include forming a question, searching the evidence, evaluating the evidence, integrating your findings into practice, and evaluating what you have done. And then of course, repeat. So it's kind of like a never-ending cycle. Then we jumped into what a research report format should look like. So what does a good paper look like? It should have a title, it should have an abstract, it should have an introduction, the summary of the current knowledge of whatever it is that you're studying, and a design. Methods are always important because they need to be repeatable, so that way if anybody else wants to take your research and say, I think I can make this better, or I think that this is wrong and I can disprove it, they need to be able to repeat your work directly off of your methods. So including, I know we learned this in undergrad too, including the most minute details, like, okay, I know you did, just basic height and weight. What was the machine that you used? So I can use the same machine to make sure I get the same height and weight. Very, very small details like that. So then of course the results, and then the discussion is kind of the bread and butter. What did you find out while you were doing it? Expand upon those results and compare to previous research, and that's really where you can kind of make your case on your research. And then obviously conclusions, what are the clinical relevance going forward, and then references, of course. Those are pretty straightforward. And then we learned a little bit about external validity versus internal validity. We talked about relevance versus quality of papers, and we kind of went through a process where, hey, what does everybody think is more important, relevance or quality? My answer was relevance. Obviously, the ideal answer is the research that you're going to be looking at is going to have high quality and high relevance to whatever it is. But I was like, there's so much research on physiology and these different things not done on humans, so like the quality of that might be high, but the relevance to what I'm looking for isn't really that specific. I would rather have research that's maybe a little bit lower on the quality scale, but it's high in relevance, so that way I can apply it directly to my patient. And then it goes back to the 5 questions that I asked at the beginning. If I apply it, I need to evaluate it. Well, and then I need to figure out, did it work?
Yep.
And then maybe pitch it aside or keep it for further for later time use. So that was pretty good stuff that we covered there. Again, external and internal validity. and how we can use it going forward. So that was pretty much it. Pretty short class because of the quiz. Took up about the first 15 to 20 minutes, and then we only had another 30 minutes to work in class. So that was it for evidence-based practice this week. And then, like we just discussed before, Josh is going to go ahead and take clinical science.
Clinical science was one of our other classes that we had an exam in this week, but we had lecture on Tuesday brushing up on our last few slides. So we were talking about medications and kind of those adverse drug reactions to them versus side effects that you take with any medication.
Mhm.
So first off, side effects, which we're more familiar with, we think about all the time, those are predictable. So if you're taking the correct dosage, you're probably going to expect to have something along in those within the guidelines. So say I take just 2 pills and there's a side effect of like a rash for 20 minutes. You can expect that to happen. It's not necessarily going to happen, but it's something that isn't going to be a detriment to you in the long run. It's something that everybody knows that it's a possibility when you take it.
Mm-hmm.
But an adverse drug reaction is like maybe like allergic to a medicine of some sort. So you have your mild, moderate, severe, lethal stages within it. Now if it's mild, you're probably going to be fine. No real issues there. But the moderate beyond, that's where we're going to have to look at getting maybe a different medication, especially with certain medications will clash with another and cause these adverse drug reactions. So with our moderate, we need to change the drug that we're being prescribed, or one of the other that's working against the other drug. The severe, you're looking at life-threatening situations, and then the lethal, obviously lethal death. So we don't want to be in that at all. So that's why as PTs we need to know what our patients are taking, be able to inform them if it's not ideal situation, and be looking for any signs of these drug reactions when we're in the clinic as well, working with the individual. So then on Thursday we had our exam. Probably, I know I'd studied the least for this one because of the other 3. Well, we had the quiz and then the practical and exam, and it's with a week of 4 essential tests. You have to budget your time where you think you're going to need it the most. And I know I used the least amount of time for this one, but I still feel like I retained the knowledge that I needed to, and I passed the exam. So I think that's kind of shout. I think that's the most important thing, is just to pass. But in a week where you have so much going on, that really is all that's the most important thing in my opinion.
Yeah.
Because I mean it's a lifelong journey through learning all of this information, so you're not always going to get 100% of the info all the time. So for me, I was pretty pleased with surviving the week and coming out of there surviving. It was a week of survival and being able to walk out of there, and it was nice to be able to have the immediate feedback, I think.
Yeah, I love that.
So we took it on computers, whereas most of our other things have been on Scantrons or written or performing the test. It was nice to submit it, and then I was a little nervous when I clicked the OK because I wasn't sure. I was like, oh no, what did I do? But it turned out all right. So.
Yeah. And yeah, I agree with that 100%. Like, I love submitting it and hitting the OK. And I personally didn't do as well on it as I would like to, but again, passed. And it was a pretty straight shot test. Like, there was nothing on it that I didn't expect.
Yeah.
It was just being able to recall that information. So reading through the notes and the lectures and the PowerPoints, I definitely had the idea of the information that was presented. I just, wasn't able to recall everything that I wanted to. So, you get up and you're like, it kind of gets jumbled in your head. You recognize 2 things and you're like, is it that one or that one? And then you just kind of pick and go.
I don't think there was a single question I was like, oh, I never remember talking about this at all. I think everything was talked about, I think, pretty detailed for the most part. It was just making sure that we actually recalled it, noticing, because he talks about the class being like a foreign language class. It kind of is, because there's words that I have no idea had no idea what they meant coming in. Just medical terminology with the drugs, and it's a medical terminology class in a way.
I mean, pathology itself is a lot of it's at the cellular level, and it's not something that we're going to be working directly with, but we do need to know these little things because they have implications in the clinic. Like he was just saying, the adverse drug reaction thing, and, you never know what a client's going to be taking, and you aren't professionally licensed to give them any kind of advice on that, but you can say, here's what I know, and then you can take it for what it is and kind of run with it, or you can refer them with your clinical expertise back to the physician or to somewhere else.
We need to know enough knowledge to be able to answer their questions that
Yeah.
they may have, or be professional enough to say, I don't know.
Yeah.
Like you said, refer to somebody that does know.
Yeah, so like I kind of shot through that test and maybe should have went back and checked a few of my answers just to double check, because one of them I remember being just simply being hypo versus hyper, and I was like, oh, hyper, I got it, and then I went back through and realized it was not exactly what I thought it was. So that's just my own fault. You just got to take it and own it. Again, another benchmark to know what to expect for next time. So
Learning process.
I'll be able to compartmentalize how I study for that class going forward, and then hopefully knock it out of the park. So again, passed. So hey,
that was all the exams this week.
that was it. That was all the
it.
exams.
I cannot believe we don't have a single exam this week. Do we have a quiz? I think we got a quiz on Monday though.
For what? No, I think it's the following week.
Oh yes. So
Yeah,
nice.
when you guys have your anatomy exam,
Yeah.
I think.
Sweet.
So
We have project going on.
you guys had a class afterwards, but I bounced out of there after the test, and I was home free. Thursdays are our Fridays. But yeah, that was it for clinical science, and then
Last one.
yeah, you'll bring us home.
Last one, professional topics. This is our kind of real world, getting out, talking about issues in the PT world. We finished our ethical discussions on Tuesday, and we've been assigned a paper. We were assigned this a couple weeks ago, but now that we've had our tests, that we're going to focus up now on our ethical paper. We get to do it in partners, which is nice. But we need to do it in partners because it's a tough assignment. So I think last week I spoke about, we were given a situation with either it was a PT in a clinic that has to see multiple patients within an hour, more than two. So it's not just they're seeing two, it's like they're seeing 3 or 4. And we're looking at it from the different views. Is this ethical? Is this good for the patient? What do I do? Am I going to lose my job if I don't do what the director's wanting me to do? So now we have our own assignment on our own that we're going to tackle and look at all the different angles and come up with the best solution. So that's what we have coming up in the next week for that class. And then on Thursday, we had it was in a way fun class because we got up out of our seats, did an activity, especially after a long week that we had. To do something non-lecture based was nice. We looked at the diversity within the populations that we'll be working with. So we had an exercise. The one question that stuck out to me that we did was we had 6 options to choose from. It was a question of, when you first see a person, what's the first thing that you notice about them? It was like their gender, their skin color, what they're wearing, their religious symbols, and a couple other ones that I don't quite remember. But you just went to a different part of the room and stood there based off of what you, as a person, perceive when you first judge a person. So you're based off of your visual cues from that individual. And then we got to talk about why we went to that location.
Mm-hmm.
So it was an eye-opener, like as far as what I look at in a person. And it's not like we look at a person in a negative way, but it makes us aware of what we are perceiving when we first see a person.
Mm-hmm.
And we're going to be working, maybe not so much in West Michigan, because we're pretty same. Like we have a lot of white Caucasian people here on the west side. There's not as many non-Christians. There's a lot of Christian faith. You have Catholic, and then traditional, just all kinds of different Christian views.
Yeah, different reformations and whatnot.
Yes, but we don't have a huge Muslim culture. We don't have a lot of Buddhists. We don't have that type of
Diversity
here. So we have to talk about these issues because we don't always see them. But when we get into maybe we go on a clinical we can, I think, go to a different country and do things. So you need to be able to communicate with different religious groups on how who's like making the decisions, because it's not always the patient that gets to make the decisions. In different religions, maybe the head of the household's making all the decisions. So for me, I came from a very like white middle class town, so I didn't have that much diversity growing up. And talking through these issues, being aware, we were given a link to see what different cultures use as far as like how they go about their business, like in the medical, like when they go to the doctor, what should you expect from, or how should you interact? So it gives you kind of some pointers and gives you something to learn about with different cultures, different ethnicities, immigration. We have people coming from that don't speak maybe that much English and aren't accustomed to Western culture. So it's something that I think is going to be a little bit of a learning curve for us. And I really like the fact that we have this class to talk about the tough issues in being a PT, because it's not just working on muscles and working getting their nervous, they're getting their cognition better. We're working with people, and people have all different backgrounds and lives, and we have to be open to serving the patient whatever best way is best for them. So I like it a lot. That's just me personally.
I like it a lot.
Yeah. So I guess that's it for our week.
Yeah.
Anything good? It's Michigan State week, by the way.
Yeah. So we're gonna end this segment with something good for you, since it is hate state, beat state, little brother week. I've been getting some memes from some of my friends, my Michigan friends, and then some of my Michigan State friends. It's funny actually. Michigan State fans, when they know they're down, they don't squeak.
Oh my goodness.
They don't say a word. Like, they won't come at you. Michigan fans, it doesn't matter. They're kind of a little bit arrogant, beyond themselves. So even when they're bad, they come at you like, we're gonna beat your behind this week. You betcha. So with that being said, I think this is one of the greatest speeches of all time.
We want the Big Ten championship, and we're gonna win it as a team.
Objective to beat Ohio State, we accomplished.
Tell you something, Michigan's no creep ball. Don't you ever think that.
They thought we were an underdog, but they didn't know us. Can't go around celebrating because, as you know, they put this schedule. We got the 3 top contenders back to back. We'll save all of our real celebrating until such time as we win this Big Ten championship.
The team.
You take care of yourself. You think football. You go to school, and you get ready to win the Big Ten championship and go to the World.
We want the Big Ten championship, and we're gonna win it as a team. They can throw out all those great backs and great quarterbacks and great defensive players throughout the country and in this conference. But there's going to be one team that's going to play solely as a team. No man is more important than the team. No coach is more important than the team. The team, the team, the team. And if we think that way, all of us, everything that you do, you take into consideration what effect does it have on my team. Because you can go into professional football, you can go anywhere you want to play after you leave here. You will never play for a team again. You'll play for a contract, you'll play for this, you'll play for that. You'll play for everything except the team. And think what a great thing it is to be a part of something that is the team. We're going to win it. We're going to win the championship again because we're going to play as a team. Better than anybody else in this conference, we're going to play together as a team. We're going to believe in each other. We're not going to criticize each other. We're not going to talk about each other. We're going to encourage each other. And when we play as a team, when the old season is over, you and I know it's going to be Michigan again. Michigan.
So I don't know about you, but just being a sports fan in general, it doesn't matter who you cheer for. That hits you deep. That's a good speech. So, I mean, huge Michigan fan, but if I heard that from any other team, I'd be like, dang, that's a sweet speech. I'd love to hear that every time. Make me run through a wall. And you play sports at a college level, so you understand it a little bit deeper than I do. at the high school level. But that's all we have for this week. Any last ifs, ands, buts, comments?
No, I'm gonna go sleep this weekend.
Yeah, I definitely need to catch up a little bit. Keep this
Instead.
cold.
Get ahead now instead of
Yeah.
just treading water.
Yeah.
Get ahead this weekend.
You're gonna actually swim a lap.
Yeah.
All right, that sounds good. We'll leave it at that, and thanks for listening, guys.